Hey everyone, welcome back to my channel. I'm Sheila G, the PAC, and today's going to be another Derm Mimickers episode where we talk about two skin conditions that look very similar but are in fact very different. For all things dermatology, of course, you know what to do. Don't forget to like, comment, and subscribe to my channel. Let's get started. The two skin conditions that we're going to be talking about today include intertrigo and inverse psoriasis. These two look very similar but are very different as far as their cause and the treatment. So let's start with intertrigo because it's a little bit more common. Now, intertrigo is a rash that forms in folded areas of the skin. So under the breast, the abdominal folds, under the arms, and the groin area. It tends to be a little bit more common in those who are either overweight or obese because it's caused by heat, moisture, and friction. So skin-to-skin contact that irritates the skin, and then it becomes complicated by yeast that's already living on our skin. It's part of our skin flora. And so this rash can be very bright red, it can be itchy, and often painful for patients. It can even get so irritated that the skin may crack or fissure. The skin also becomes macerated, meaning it's very softened and thinned out due to all that excessive moisture. Now, for those who have intertrigo, we tend to see this pattern where it kind of waxes and wanes, meaning it comes and goes, and we see it correlated with, again, more moisture, heat, and friction. Now, some patients can get what's called Candida intertrigo, which is caused by a different type of yeast known as Candida albicans, and that's the same yeast that causes vaginal yeast infections as well as oral thrush. Now, with Candida intertrigo, we specifically see what's called satellite lesions, which means we see these tiny little red bumps or pustules that form on the periphery of the rash itself, and that's pretty diagnostic of Candida intertrigo specifically. Intertrigo more commonly occurs in adulthood, but we can even see it in babies and infants as a form of a diaper rash, and it can happen on the neck as well as other folded areas of the skin in babies too. As far as the treatment for intertrigo, we often combine low-potency steroids such as hydrocortisone or Desanide with an antifungal cream. So that could be miconazole, econazole, ketoconazole, or commonly nystatin, which also treats candida yeast as well. Again, we use topical steroids to help with the inflammation that's associated with intertrigo, but we have to be careful with what strength we use because we're dealing with intertriginous areas, again meaning body folds, and so we can't use super high potency steroids because that can lead to atrophy or thinning of the skin. So it's better to use a low potency. A lot of the times we also recommend antifungal powders such as Zeosorb to absorb excess moisture and hopefully serve as somewhat of a preventative step in terms of developing the rash again. But it's not always perfect. A lot of patients have to use that along with their active treatments to treat the rash. Now, another thing that can be done too is using skin protectants such as diaper rash cream. Yes, you can use diaper rash cream because a lot of these contain zinc oxide, which serves as a barrier, and that's what's causing the problem, skin-to-skin contact and friction. So if we can use a barrier like zinc oxide, that helps tremendously in terms of preventing the rash from coming back up. In more severe cases of intertrigo or those who have Candida intertrigo, a lot of the times we combine prescription topicals with oral medications as well. But what happens if we think someone has intertrigo, but they fail those traditional treatments? Well, we could be looking at something called inverse psoriasis. Now, similarly to intertrigo, inverse psoriasis affects the intertriginous areas of the skin, so those folded areas of the skin. And the rash itself can look very similar too. So it's a very bright red, irritated rash that can be itchy and somewhat painful. Inverse psoriasis is a particular variant of psoriasis. And so there are four main subtypes. We have plaque psoriasis, which is the most common, again, inverse psoriasis, pustular psoriasis, otherwise known as palmar-plantar psoriasis, and then we have erythrodermic psoriasis. Now, just to recap, psoriasis, as opposed to intertrigo, is actually an autoimmune condition where the immune system is attacking the skin and causing a lot of inflammation and high cell turnover. And so because of that, it can affect other areas of the skin like the nails and the joints. Inverse psoriasis, like plaque psoriasis, is very well defined, meaning we can easily see where the rash starts and where it stops. And it's also very bright red and inflamed, but it looks the same as intertrigo. Intertrigo looks that way too. So how do we really distinguish the two conditions, and what clues can we look for to make the correct diagnosis the first time around? Well, you want to ask about history. When did they start the rash? Again, with psoriasis, we tend to see it pop up in adulthood. Usually late adolescence is kind of rare, but it's usually later in life that they develop this rash. Also, we want to ask about family history. Does anyone in the family have psoriasis? Because it's a hereditary condition. We also want to look for other clinical signs, like examining the nails. Do they have any pitting in the nails? Any discoloration of the nails that may suggest more of a systemic issue like psoriasis? Ask if the patient has experienced any joint pain. Also ask about any other systemic chronic conditions, like other autoimmune conditions or any other inflammatory conditions, as sometimes psoriasis can come along with those. We also have to look at the pattern. If the rash comes and goes, is it sporadic? Is there something that's making it worse, like heat and sweat, which can happen in both conditions, but does it only appear after heat or sweating? Or is it always there but just exacerbated by those things? We have to ask those questions. But if we can't make the diagnosis clinically, there's a couple options that we have. We can either do what's called a KOH prep, which basically looks for fungal or yeast hyphae, which would be present more so in intertrigo and not present in inverse psoriasis. Or we can do, or commonly we do a punch biopsy, where we take a sample of the skin and we send it to the lab for pathology so they can read it. And that will give us the diagnosis most of the time. Now let's talk about some treatments for inverse psoriasis. Topical steroids, as with intertrigo, can be attempted and they can help temporarily, but we know that antifungal medications specifically are not going to work in inverse psoriasis. Some other things that can be used topically, specifically for inverse psoriasis, would be vitamin D derivatives like calcipotriene. Then we have calcineurin inhibitors such as tacrolimus, pimecrolimus, which are safe to use in intertriginous areas of the skin. And then we have new, more novel topical medications that are very specific to psoriasis, like topical Zoryve or Vtama. For more systemic treatment, we have things like Otezla, which is a pill for psoriasis, and then we have biologics, and we have many biologic treatments now, but those are injection medications that can be injected into the subcutaneous fat layer and really target the inflammatory cycle that's involved in psoriasis. So there you have it, the basic differences between intertrigo and inverse psoriasis. Thank you guys so much for watching, and if you have any questions, please feel free to comment down below. And don't forget to like and subscribe to my channel for all things dermatology. I'll see you next time.